Now I will talk about Part 4, Metabolism Imaging. Metabolic imaging is the most mature technology in molecular nuclear medicine and has been widely used in clinical diagnosis. Altered metabolism is a hallmark of the cancer cells. Tumor cells increase their metabolism to support their uncontrolled proliferation by taking up nutrients from the microenvironment. Molecular imaging of tumor metabolism has gained considerable interest since preclinical studies have indicated a close relationship between the activation of various oncogenes and alterations of cellular metabolism. Several clinical trials have shown that metabolic imaging can significantly impact patient management by improving tumor staging, restaging, radiation treatment planning, and monitoring of tumor response to therapy. Now, studies of metabolic activity of cancer cells and the imaging techniques for tumor glucose, lipid, amino acid metabolism are increasing. The most famous molecule is F18-labeled FDG. Professor Wagner named this molecule FDG as a millennium molecule. As glucose analog, F18-FDG will be ingested by glucose efficiency cells such as brain, kidney, and malignant cancer cells. In such cells, the phosphorylation process will prevent the release of glucose from the cells in its original intact form. 2 oxygen in glucose is necessary for subsequent glycolysis. F18-FDG is the same as 2-deoxy-D-glucose and cannot be metabolized in the cell. Thus, formed F18-DG will not undergo glycolysis before radioactive decay. As a result, the distribution of 18-FDG can well reflect the distribution of glucose uptake and phosphorylation by cells in vivo. Here shows the structures of FDG and glucose. Left is the glucose, right is FDG. You may say these 2 molecules is similar, and we can label FDG with F18, this radioisotope. The clinical application of 18-FDG metabolic imaging. First, in tumor. PET has become a standard in the staging cancer, as well as can be used in the locating unknown primary malignancies, monitoring disease response, and identify a disease recurrence. So mainly for tumor area, we can use FDG to do early diagnosis, staging, early or late, recurrence and metastasis determination, and to evaluate efficiency of therapy, for example, for chemotherapy, for radiotherapy, and after a couple of curing courses, you may evaluate the result. And this is a picture shows the oncology PET FDG, F18-FDG. And this is a 68-year-old male suffer from pancreatic cancer and melanoma ganglion. You can see bone and diffused metastasis. We use F18-labeled FDG, 10 millicurie, and after 13 minutes, we get this image. And the second area, F18-FDG imaging in nervous and mental disease. Glucose is a principal source of energy for the brain, and the dynamic response to of glucose utilization change in brain activity is still not fully understood. The brain represents only 2% of the body weight, but it receives 15% of cardiac output, 20% of total body oxygen consumption, and 25% total body glucose utilization. So our brain uses a lot of glucose. F18 FDG metabolic imaging research on nervous, mental disease, brain function, metabolism of cerebral cortex and brain behavior, and different physiological stimulation of thinking activity. Positron emission tomography PET with F18 labeled FDG allows quantitative measurement of the cerebral metabolic rate of glucose, we call CMR-GLU. And positron emission tomography with 2 F18 labeled FDG has been widely used for evaluation of continuous glucose metabolism in several neurodegenerative disorders. And this picture showed FDG metabolic imaging, showed carbon 11. We use dopamine D2 receptor imaging and carbon 11 labeled chemicals for serotonin transporter imaging. You can see this F18 FDG image showed our brain have the high metabolism of glucose. And the third area of F18 FDG imaging uses myocardial viability evaluation. It is a gold standard to distinguish myocardial necrosis and hibernation to provide the basis for the treatment of coronary heart disease revascularization. Non-invasive assessment of ischemic heart disease remains a challenge task, even with a large armory of diagnostic modality. PET is an advanced radionuclide technique. It has been available for decades. It is now becoming established in clinical practice and is increasingly used in diagnosis and risk stratification of the patients with ischemic heart disease. PET myocardial perfusion imaging has a mean sensitivity and specificity of around 90% for detection of angiographically significant coronary artery disease. It is also highly accurate for access prognosis of patients with ischemic heart disease. Depending on the radio tracers used, it can provide information not only on myocardial perfusion, but also on myocardial metabolism, which is essential for a viability assessment. The potential of this imaging technique has been further increased with the introduction of hybrid scanner, which combined PET with CT, or cardiac magnetic resonance imaging, MR. Combined PET-CT, combined PET with CT, combined PET with MR, offering integrated morphologically and functional information and hence comprehensive assessment of the effect of atherosclerosis on the myocardium. And this picture shows a cardiac SPECT result. And you can see use the tetramine-M labeled MIBI to do the cardiac blood perfusion imaging. And you can see the myocardial muscle living. And this is using a PET to do myocardial metabolism evaluation. Left is a normal PET scan of a heart, and the right is imaging of heart which has been had a myocardial infarction. The arrow points to a dead myocardial tissue. Therefore, the patient will not benefit from the heart surgery, but may have other forms of treatment prescribed. There are many developments on the horizon for cardiac PET in coming years, with a new scanner technology and new radionuclides providing a potential application of directly aiding the patient management, as well as improving understanding of multiple cardiac conditions. Although these developments are currently outpacing research that demonstrates their efficiency, it is reasonable to expect cardiac PET will play an increasingly important role in the future. Although F18 labeled FDG is by far the most frequently used radiopharmaceutics in metabolism imaging, glycolysis is not only a metabolic process or biochemical pathway that can be visualized. In addition, F18 FDG PET can be limited due to the non-specific nature of alteration in glucose metabolism. So recently, some new tracers developed, such as amino acid, such as calcium 68 labeled somatostatin analogs, and F18 labeled FMT, F18 labeled FET, and carbon 11 labeled MET, and F18 labeled FDOPA, and F18 labeled FLT, 18 labeled choline, F18 labeled hypoxia specific tracer, F18 labeled FAZA. A lot of new tracers developed. Several properties of copper-64 labeled chemicals may limit its clinical use in prostatic cancer patients. The decay of copper-4 is suboptimal for clinical PET-CT workflows. They provide 18% beta-positive decay as half-life 12.7 hours. Accordingly, acquisition time needs to be increased significantly to achieve the counting rate and imaging quality observed from GA68, F18, or carbon 11 labeled antigens. Okay, that's all for this part.